Okay, correct me if I'm wrong. The Public Officers Medical Fund was established in 2012 when the civil servants forfeited their medical allowance for insurance scheme. Like many are saying, they're contributing double for SHA and for the fund. Why is that?
Now, for SHA, what SHA is about universal health coverage. It is like the bare minimum that each one of us needs to have. Suppose you lose your job here, Ashley, what are you going to use? SHA will be there for you. So it's a universal health coverage. And you can see from the benefit package, there's quite an enhanced benefit package when you compare to NHIF. And really, this is what, as a country, we need to focus on and move forward to ensure that SHA works. Because when SHA works, then our health insurance as a country is going to be good. Any one of us can access the care, that universal health coverage, you see. So what we are encouraging Kenyans, let us all register. When we all register, when we all contribute, then there is no need even to have those parallel or fragmented medical schemes. So yes, we are working on the public officers medical scheme, but what we are saying that critical to us, all of us, whether you're rich, whether you're poor, you know, you have a job or you don't have a job, you know, whatever kind of background you're coming from, SHA and Taifa Care is what will work for all of us. And really the message is that let us all register and contribute so that we can be able to access care.
So then, is there a timeline in ironing out these issues? Because next week is just a few days away.
Yes, yes, we are working towards that. And what we have done, we've allocated some resources to support the scheme. So you know, for the police officers, they were under another scheme. That was the private practitioners medical administrator. That was the medical administrators Kenya Limited scheme, which is by a private practitioner. They were not under NHIF for a whole 2 years. And now what we are telling them, they need to register for SHA. If they register for SHA, they can access healthcare services like any other Kenyan. Then after that, then there's the top-up from their medical scheme that they have. So ultimately, SHA is the way to go. We're talking about medical students or interns out there who don't have a job. They can be able to access this very same care. And I remember myself being an intern. I remember being, a postgraduate student. You could offer the services, but the very services that you're offering, you can't afford.
Okay.
Yes.
And we'll talk about SHA in length, but you know, the unions are claiming that the move to deny public servants medical cover is a deliberate effort to undermine the workers' welfare. Is this the case? Because then where is their money going?
Absolutely not. That is not the case. We are working towards it, and these are actually maybe we will have the public servants, the group coming here to discuss that. But as a ministry, we are supporting them to have a medical scheme. But the thing is, Kenyans are not getting. Social Health Authority is universal health coverage. It is for all of us. Whether you have a job or you don't have a job, it's for all of us. So why not have the bare minimum, which is SHA?
CS, allow me to interject. Their issue here is that they're having double deductions and they're not getting value for their money. So it's not even about SHA, it's about value for your money when it comes to healthcare services.
Yes, so what I'm telling you is that we are working towards having the medical scheme. We have been able to allocate resources. Yeah, the public service has been able to allocate resources, and we have a scheme they are working. Yes.
All right, so let's now talk about SHA. So majority of Kenyans claim that SHA is not working for them. The government insists SHA is working. From where you sit as the CS, if SHA is working, what exactly is working in SHA for you?
All right. Now I'll start from NHIF. When you look at NHIF, there was accrual of debt for many years, and actually they were anticipating that it would crash in 2022. So we were going nowhere. It was actually plummeting, and the debt had accrued to 30 billion. Okay, so now NHIF was really not the way to go, and everyone knew it, but no one was out to call it. Secondly, when you look at NHIF, the administrative costs were at 37%. Yeah. So meaning the contribution of Kenyans, 37% of it went for administration, and then the rest would go for service to the people. When you look at SHA, only 5%. So meaning there's more money for health service delivery for Kenyans. Another thing is the false claims. Okay, so what we saw in NHIF, there were multiple false claims. I can give an example of a leg being amputated 5 times, you see, or a mother delivering 50 times in a year. So there were a lot of false claims that were coming up, yeah, and again, that one was a way of corruption. And what we are doing for SHA is that we are ensuring that we have a digital platform. And in this digital platform, we continue to enhance it so that these, inefficiencies, this corruption that was occurring, we are able to address exhaustively. And one of the ways you can see is transparency and accountability. When you look at the site, you are able to see that we have printed all the facilities, how much they've been able to receive up till now, okay? So if anyone has a concern, then they can raise their grievance. There is a link where you can click and you're able to see what are the concerns, yeah? Because what we noticed is some private facilities, okay, were complaining that they have not received any money, but yet there were errors. There were errors in terms of the name of the facility or the account, okay? So what we are saying is that it is open. In fact, right now, when you listen to private facilities, they are concerned. They're like, now when you're exposing us of how much we've paid, people will start asking for raise, you know? And thirdly, when you look at NHIF, it had multiple schemes. Now, for the multiple schemes, you will notice that for the civil servants, they were getting a better deal. Okay, so they could travel, abroad for services, etc., at the expense of the ordinary Kenyan, whose amount was limited, right? And in some private facilities, it could only pay for a bed. Now, when you look again at SHA, you see that there's enhanced health package. We have now mental health. We have oncology services, and we have dialysis services that have been expanded. We have critical care services like ICU, which was not there under NHIF. So there's enhanced package. Again, the vendors who are causing corruption and digitization is helping. And again, fictitious facilities. There are some facilities which were non-existent. There was a one-room facility that would claim for ICU beds of 50, or that could claim for dialysis, And a critical thing that I need to talk about is the primary health care. In this kind of a scheme, what we are strengthening is the primary health care facilities. Why is that? Long time ago, you remember, okay, maybe you were not born, but we used to go...
Not as young as you think, but okay.
So we used to go to health centers and dispensaries, and medicine was there.
Yeah.
But right now, what's the norm? Everyone assumes that the health centers, dispensaries have nothing. Everyone has now, flooded the level 5 and level 6. What we want to do is to revive the primary healthcare facilities. Yesterday, when we were with the meeting with the Council of Governors on USG funding, I remember, Honorable Waiguru was looking and saying, oh my goodness, you mean my health center has gotten all this money? Why should it get all this money? I expect this to be at the higher levels of care. Okay. But what we are saying, we want to capacitate the primary health care so that right at the door, close to your home, close to your neighbor, you should be able to access those very services. And then now for level 5 and 6, those are the referral, the patients who have complicated. And again, capacitating the public facilities so that we can improve the services for all patients.